Good evening, everybody. I would like to extend a very warm welcome on behalf of RCOG West Zone to everybody who has gathered here today. And we've had earlier one masterclass on endometriosis with the ICOG. But as you know, that endometriosis is a disease which affects right from adolescence up to menopause. The first webinar looked at the different modalities of management, and we had a number of laparoscopic surgeons joining us. This time, the focus is slightly different. Dr. Archana will be talking on the ultrasound about endometriosis, how to diagnose it. And then we have a wonderful panel moderated by Dr. Rupali, which will look at different case scenarios right from adolescence to menopause. And I'm really very happy to have so many seniors here who have joined us. And I'd like to welcome them, and we'll start this webinar. Thank you.
Thank you, Purnima.
Thank you. Thank you, madam. Thank you so much. At the outset, I would say a big thanks for giving me this opportunity today, Dr. Archana ma'am, as well as Dr. Purnima. We know that this focus series is none other than Dr. Archana ma'am's brainchild, and it was very well supported and encouraged by Dr. Purnima ma'am. So we are here month on month. We will be coming up with these series, and we'll be covering up different topics. And we're trying to get into all the recent advances as well as the guidelines. So it will be more or less like a practical based question answers rather than just theoretical what we routinely come across. So I call upon Dr. Manila ma'am to introduce Dr. Archana.
Thank you, Dr. Rupali. It's my proud privilege to introduce the course director of this webinar, our own Dr. Archana Vasil, an accomplished surgeon, infertility and fetal medicine specialist. She is a dynamic director of Akash Hospital, Imdad. Dr. Basir's journey is a blend of excellence, dedication, and leadership. With prestigious qualification of FRCOG from Royal College of Obs and Gynae, she has consistently set benchmarks. After her Guinness World Record holder status, her contributions has crossed boundaries, making her at par in the field of gynecology. She has been serving Foxy when most of us were very young. She has held a lot of positions in the Foxy, like Chairperson Foxy Imaging Science Committee 2015, Organizing Secretary of ESAR held at Indore 2016, Managing Committee Member ESAR, IAGE and ICOG. She was also member of Imaging Science Committee AOFOC and Imaging Science Committee Chair CEFOC. She was Vice President Foxy 2020, and presently she is Chairperson of MP ISAR and Fellow Representative AICC RCOG West Zone, Joint Secretary ISPAL, and Organizing Secretary of a very successful AICOG Indore. Her career reflects not just position held, but a legacy of service, dedication, and innovation. With an impressive track record in academics, organizational leadership, and clinical expertise, Dr. Basir stands a role model for most of us and continue to inspire me and many others with her vision and commitment. With that, I would like to invite Dr. Archana Vasil to start.
Thank you, Manila. I'm overwhelmed by the CV you read. Thank you so much for really being part of this webinars. And at the outset, let me welcome all the dignitaries on the dais who have joined from different parts of the country and different places they are. And thank you, Dr. Purnima SATOSKAR, for giving us this platform of RCOG West Zone to hold our focus series. And I'm really thankful to my coordinators, Dr. Rupali, Dr. Manila Kaushal, and Dr. Anjum for connecting with all the faculties and handpicking all the speakers and all the guest of honors, chief guests, and all the panelists. I'm really glad that we have Dr. Muralidhar Pai with us, who is our guest of honor, and Dr. BASAB Mukherjee, who is our guest here today. You know, the purpose of keeping, as Purnima has said, endometriosis is a big subject and its incidence is quite big, and we need to talk about the practicality of endometriosis. So it is very, very important that we know nitty-gritty of endometriosis as it is increasing and patients are coming to us with the diagnosis of endometriosis. We need to keep ourselves updated with the diagnostic modalities as well as the treatment options available, surgical and non-surgical, which will be discussed in the panel. So to introduce our guest of honor, may I have a CV of our guest of honor here, please? As we know, Dr. Pai, we were just talking about his extracurricular skills apart from the academics, like music and all. He is Dean Sikkim Manipal Institute of Medical Sciences, Professor of Obs and Gynae, and he has 37 years of academics, 30 awards, 15 international fellowship, 208 publications, 3 textbooks, and 850 guest lectures. So I think it's like a person who is there on our webinar with so much of academic excellence, and it will be nice to have his inputs on this webinar and his blessings and advice to us. Because as I think in the first focus series of webinar, when we had Dr. Jyoti Unni and Suchitra, they said this is a really good platform where we can connect all our COG West, East, North and South zones together. So have a blend of faculties on this webinars from all over the country, not only the West zone. So that's the whole purpose of having all of you here, and to give us inputs and how really we can do better in our next focus webinar. So over to you, Dr. Pai.
Thank you very much. Good afternoon, everyone. I think it's good evening in India. Okay. Because I'm joining from UK here right now. Thank you so much for inviting me as guest of honor today. It's such a good pleasure to be among the stalwarts of RCOG college representatives in India. And today's topic is actually my favorite topic, that is endometriosis. There was a time when I used to tell students that to diagnose endometriosis, the gold standard is laparoscopy. And all students used to recognize me by that particular statement I used to make, even after, much years later after they pass. But now the things have changed so much. And today's topic is diagnosis of endometriosis by ultrasound. In fact, now they have gone to an extent saying that laparoscopy is not required to diagnose alone. If you want to diagnose, you can diagnose by so many other things. You use laparoscope only if you want to both diagnose as well as treat. Even for treatment, laparoscopy is not the first line of treatment. There are so many other modalities now that they have come up, and the second panel is on that itself. So I'm really, really curious to listen to Dr. Archana, who is a fountain of knowledge, and she's the most experienced person in the country today to talk about this, the diagnosis of endometriosis by ultrasound. And then Dr. Rupali, who is going to moderate the panel on management. I'm sure she'll be touching upon the different modalities of management, I'm sure including laparoscopy. So this is a wonderful initiative that is taken by Dr. Archana and Dr. Purnima and others. So I'm happy to be the guest of this particular webinar, and I'm looking forward to listening to you all. Thank you so much.
Thank you, Dr. Pai, for your words of wisdom. You know, once Barack Obama said that if I have to make a talk, of 2 hours, it's easy. But if you have to make a speech of, shorter speech, it takes a lot of time. What I am seeing in your CV, so much of academics and so many guest lectures, you're just put in 2 lines. So it is really very, very impressive CV with a very, just presenting in 1 slide. And as you said, that endometriosis is something which there are other modalities, and ultrasound is the one which we should know and we can perform. Laparoscopy should be for diagnosis and treatment, both. So please stay with us. And now I would like to invite Dr. BASAB Mukherjee, a dear friend and another person who is multi-talented person, BASAB Mukherjee. He is has organizational roles as we
Actually,
all
don't need to read it. Archana, don't need to read Archana, don't need to.
just few lines, BASAB, about you. I think we all know you. You have
No,
a
no.
vice president Foxy position. You have many awards, and you have conducted AICOG, Pito Vision, and everything. And BASAB, over to you for your inputs and how really we can do with this focus series much more in this series and how we can go ahead. Thank you so much for joining.
Thank you, dear Archana. I think, Archana, you really don't need any advice. You are smart enough. You have 15, 20 years of experience with you. Your career and my career in Foxy has more or less mirrored. You've had the chair, so have I. So we have a lot of mirroring of our careers in Foxy, and I wish you the best as you take it forward to the next level. That's the first, I think, message which I would like to leave. RCOG is typically known as an academic organization, and we usually stick to academia primarily. So we have to keep these intros limited, and I think that's what people would log in for. Really want to hear the main core subject, which your wonderful conveners, Manila, Dr. Rupali, Dr. Anjum would have prepared. So we will all be looking forward to the active academia, what RCOG is famous for. And as you said, you have it more practical, you have it with a different tinge, and I think that would be what is attractive, because webinars now are generally joined by people who really want to hear the academic subject, really want to learn from it, where conferences are joined, where you want to enjoy the fellowship, where you enjoy the camaraderie along with a little bit of academics. So I think if the people want purely academics or more of to learning, this is where people join, and this is what this is all about. I want to congratulate my colleague, Dr. Purnima. Dr. Purnima is a wonderful colleague of our West Zone. We work together in our All India circuit, and she is a fascinating lady. She has a lot of programs up her sleeve, and this is inspiring for me too, because I'm heading the East Zone. So in East, we would love to have some similar webinars where we'll be inviting you, Archana, and a lot of the people who have joined here today. It's great to see Dr. Murali. He's in UK, so he's a real RCOG representative here today. So he's nearest to the college, and so it's nice to see Murali, and I'll always love the singing videos, and wonderful seeing you. Thank you. All the best to all the team, and may the attendees and the viewers get their worth for the time they spend in seeing this, some academic input, which is very important. And endometriosis and PCOS are two subjects which we will never stop discussing in the next 1 decade. And it'll never be tiring. Every time something new comes up, and we will be discussing this for a very, very long time. Thank you for having me. Wonderful. Thank you. Bye.
Thank you, BASAB, for joining from Haridwar. And really, we'll keep our promise of academics in the RCOG focus webinar. So thank you very much, Dr. Murali and Dr. BASAB. Over to my team for carrying it forward for the academics.
Manila, madam. Okay, ma'am, we can start with your talk. Dr.
Meeta needs to be introduced. She's chairperson.
Okay. Good evening, everyone. I'm Dr. Nakhare from Pune, and I'm looking forward to hearing my dear friend Archana enlighten us about all we need to know. So, Archana, the floor is yours. Let's start.
Thank you, Dr. Meeta. And I think Parikshit will join
in a while. Parikshit sir is going to join in a while, he said.
I'm allowed to share my screen. So, good evening, everyone. And I think we move on with our topic. My topic is stepwise diagnosis of endometriosis by ultrasound. We know endometriosis is a costly chronic disease. And as Dr. BASAB has said, we will never stop talking about endometriosis in next 1 decade, because we don't know exactly what causes endometriosis. Nearly 10% of women of reproductive age group suffer from endometriosis. And if you want to know the facts and figures of endometriosis, it takes an average of 7 years for most women to get it diagnosed. Endometriosis can often be confused with or misdiagnosed as irritable bowel syndrome, or just the dysmenorrhea, which everyone gets it. And endometriosis is the second most common gynecological condition after the fibroids. So what I'm going to take in my talk, a little bit I'll touch upon definition of endometriosis and adenomyosis, ultrasound appearance of endometriosis within the pelvis, and how to assess for pelvic mobility and what to look for during an endometriosis scan. If you look at the definition of endometriosis, it is presence of endometrial-like tissue, glands and stroma outside the uterus, which induces a chronic inflammatory reaction. And endometriosis typically manifests itself in three ways: endometriomas, adhesion, and endometriotic nodules, deep or superficial. Now, what are the diagnostic modalities we have? Ultrasound, contrast ultrasound, MRI, CT, endoscopy, laparoscopy, sigmoidoscopy, biochemical screening, and histopathology, which is the definitive diagnosis. My ultrasound is the most preferred modality for assessment of pelvic pathology. You can do it transvaginal, transabdominal, or transrectal ultrasound. Why ultrasound? Because it is widely available, it is cost effective. Ultrasound scan can pick up ovarian lesions, endometrioma, and you can pick up deep invasive endometriosis also by ultrasound. Now, what are the scanning techniques for ultrasound in endometriosis? The scanning should ideally begin with survey of whole abdomen with 3.5 megahertz probe and follow it with transvaginal scan and ask partially full bladder so that the bladder wall can be evaluated. Grayscale imaging can be improved by using HI, CRI. With this, even subtle textural changes associated with endometriosis can be appreciated. And 3D volume ultrasound may be used to assess multi-organ involvement and adhesions. Surgical staging of endometriosis is stage 1 minimal disease, stage 2 mild, 3 moderate disease, and stage 4 is severe disease. So this is how when you do laparoscopy, you put a diagram and put like minimal endometriosis, mild, moderate, and severe. You can have a pro forma made, or you can have your a recording where you can put this, and any classification you can use, you are comfortable with. You can use SRM classification. I'm going to talk about on ultrasound. For the purpose of this lecture, I'll be describing how to identify structures involved by endometriosis and showing corresponding laparoscopic images to improve the correlation. These can then be staged by any classification system you are comfortable with. So let's go step by step. What are the structures which can get involved in endometriosis? Ovaries, uterosacral ligaments and POD, bowel, rectum, bladder, and uterus. Ovarian endometrioma, endometriosis are probably the most commonly diagnosed form of endometriosis because of relative ease and accuracy of ultrasound diagnosis. Although their exact prevalence and incidence are not known, they have been reported in 17 to 44% of women with endometriosis. Ovarian endometriomas are common. They can mimic other adnexal masses. They result from cyclical. The walls are thick and fibrotic. The contents consist of thick, dark, degenerated blood products, also known as chocolate cysts. If unilateral, they are more likely to occur within the left ovary, and if they are bilateral, in approximately 50% of cases, and they usually regresses substantially after the menopause. So this is a typical feature of endometrioma on ultrasound. Fluid levels with hyperechoic layer will be dependent portion of the cyst. It can have calcified foci within the cyst, that is called acoustic shadowing, this thing, and typically avascular or a low flow. And acoustic streaming can help discriminating from mucus and serous cyst adenoma. This is again an ovarian endometrioma. You can see ground glass appearance and a thick walls. And this is endometriosis may not always look the same. Notice the cholesterol deposit in this clear looking cyst. So this is an endometriotic cyst. I'll show the laparoscopic picture. This you might confuse that this is not an endometriosis, but there are like the cholesterol deposits. Images of the same patient showing the ovaries stuck behind the uterus. So see here, this is a ovaries which is stuck behind the uterus. This is the uterus. This is the endometrium, and this is stuck behind the uterus. And this is a laparoscopic view of the same patient. If you see that ovaries are stuck behind the uterus, so it can sometimes be confusing. You may appear like a clear cyst, but whenever you see cholesterol deposit, think about the endometriosis. You can have multiple ovarian endometriomas in the same ovary. You may not have just one endometrioma, but you can have multiple endometriomas in the same ovary. So pelvic scan has to be done diligently whenever you are doing for any pathology, and especially for endometriosis, to map it exactly, that how and how many endometriotic cysts are there. Otherwise, sometime you can just whenever you are taking for operation, you may take only one endometrioma and rest may remain. So a clip showing multiple endometriomas in the same ovary, if you see, and it is important that this is assessed prior to surgery in order to avoid residual endometriosis. And this is again an image showing multiple endometriomas in the same ovary, and it is important to avoid it. And these are again the ovarian endometriomas with the cholesterol deposits. So large endometriomas can easily be picked up on ultrasound, and whenever there is a picture on the laparoscopy, ovarian endometrioma, small endometriotic lesions are usually uniform and slightly hyperechoic than stroma, and these lesions usually do not change their ecostructure during different phase of menstrual cycle. This is very, very important that all of us should remember, because if it is not other kind of cyst, they may vary depending on the menstrual cycle. So this is again the endometriosis, how it looks like, and this is a large endometrioma which I just now showed you ultrasound picture. And this is endometriosis again, where you can see the endometriosis which we have seen the picture. Now differential diagnosis of endometrioma, you have to differentiate it from dermoid cyst, because dermoid cyst, hemorrhagic cyst of ovary, serous cyst adenoma, and pseudocyst adenoma. If you see here, this is endometrioma, which is a cholesterol deposit, and this is a dermoid cyst. If you look here, again there's a ground glass, again there is a ground glass, but here the most common sonographic feature of a dermoid cyst is a plug that is called a dermoid plug. This is a tuft of the hair follicle hair which appears like a hyperechoic things, and that's a dermoid plug. If you look at the hemorrhagic cyst of ovary, this is unilocular thin-walled cyst with fibrin stents or low-level echos and good through transmission. You see it's like a cobweb kind of appearance. And this is a serous cyst adenoma, again a very clear cyst with thin walls, and there is no content inside it. So there is no cholesterol deposit, nothing, but it can sometimes be multilocular cyst with a clear watery fluid. And this is a pseudocyst adenoma, usually seen as large multilocular cysts containing fluids of various viscosity. They rarely appear as unilocular cysts. You can see here the loculi, and this is the picture of the same patient, the laparoscopic picture of the same patient with a pseudocyst adenoma. Now, what are the rules of endometrioma? Single base discriminator between endometrioma and other cysts is ground glass echogenicity of cyst fluid. Sensitivity of it is 73% and specificity is 94%. It's a premenopausal status and 1 to 4 locule, absence of papillations and detectable blood flow. Ovarian endometrioma are rarely sole finding, which we have to remember. They are the easiest to diagnose. However, by this stage, the endometriosis has already reached stage 4. So women with ovarian endometriomas have more pelvic and intestinal areas invaded by endometriosis compared to women without ovarian endometrioma. So it is important to identify other structures involved whenever you see ovarian endometrioma. And again, like in endometriosis, when there is ovarian endometrioma, you might see that ovaries are stuck together and there's a kissing ovaries and negative sliding sign, that is no movement on applying gentle pressure with transvaginal ultrasound probe. It is strongly associated with presence of endometriosis and indicate a severe form of disease. So this is severe endometriosis, kissing ovaries. Uterus also is adenomyotic, and you can see here, if you correlate it with the picture shown in the previous slide, these are the kissing ovaries with a stuck behind, and it's a deep invasive endometriosis with endometriomas. Now we have learned about the ovaries. Now, how does the uterus appears in endometriosis? Due to involvement of the uterosacrals leading to adhesion, endometriosis tends to cause retroflexion and retroversion of the uterus. This should alert us to the possibility of involvement of pouch of Douglas and need for further assessment. Now, uterus in endometriosis, it like more or less it can get retroverted and stuck or pulled down by the ovaries, and sometimes it is more or less adenomyosis is they go together, endometriosis and adenomyosis, and you may see the comma sign. And this is the altered version of the uterus due to adhesions in POD. Whenever you scan in a normal pelvis, uterus direction is not, there's an angle between the uterus and the cervix is increased. And this is the video clipping of uterus in endometriosis. And nodules or implants also you can identify, they vary in size from a few millimeter to few centimeter and are superficial to deep. And nodules may change appearance during the menstrual cycle. Only laparoscopy can detect superficial peritoneal implants, while if their nodules are big, you can pick it up by ultrasound. So this is a picture of a patient whom you can see the nodule here. This is quite a large nodule, 1.43 centimeter. We know that this patient has endometriosis, and a thorough endometriosis scan was done, and we could pick up the nodules here. And this is the nodule in the uterosacral. White line, when you scan transvaginal, this white line denotes the uterosacral, and there are nodules in the uterosacral. This is a case of a moderate endometriosis. What you see here is a peritoneal hitching. So these are the signs of the endometriosis. Initially, when we were like ultrasound is very good with the high resolution, but you have put in laparoscope for some other reason, not for endometriosis, and you see this kind of structures, think of endometriosis. So this is again a moderate endometriosis. Now let's move on to the deep invasive endometriosis. Definition is infiltration of endometriotic nodule more than 5 millimeter. Its location can be rectosigmoid, uterosacral, rectovaginal, septum, vagina, and the bladder. So these are the different locations where you can find endometriotic deposits, and how really you can diagnose it by ultrasound. So diagnosis of deep endometriosis, this is a very good article, infertility and sterility, clinical examination, ultrasonography, MRI, and other techniques you can pick up. Bowel nodules, histologically definition is the presence of endometrial glands and stroma in the bowel reaching at least the muscularis propria. It involves anterior rectum, rectosigmoid junction, or sigmoid column. Typically hypoechoic or isoechoic solid masses with irregular outer margins, and they are tender on palpation. So this is a ultrasound picture where these are the bladder. You can see the bladder wall, and there's a endometriosis on the bladder endometriosis, and small internal echos, cystic areas, they are seen approximately 30% of the nodule. That's why I said in the beginning, keep bladder partially filled when you are scanning. If you completely empty the bladder, you may not be able to evaluate the bladder wall. So it is important that you do with a partially filled bladder. Now, if you see the same patient, the different axes, this is the bladder endometriosis. This is completely the bladder wall, and you see a little bit of bulge in the bladder wall, and this is endometriotic nodule. So you can diagnose the bladder endometriosis if you ask for the partial filling bladder. Bladder endometriosis mimics recurrent. The problem is they present with recurrent cystitis with dysuria, urgency, frequency, suprapubic pain, and incontinence. Macroscopic hematuria is relatively rare. Diagnosis is often delayed or not considered at all. So, I mean, if a patient is coming to you with recurrent problem of urinary tract cystitis or infection, please think about that she might have endometriosis as well, apart from other diagnosis. This is a case where a 22-year young girl whom I only delivered, her mother I delivered 22 years back. She kept going to doctor, and she presented with dysmenorrhea, and especially the dysuria and burning in micturition and all sorts of things. She never was scanned. When we insisted, she got scanned, and what we found on scan that she has hydronephrosis, and she had ureter was also dilated. And then when we investigated her further, her kidneys were non-functioning, and as you know that non-functioning kidneys need to be really removed because they can be a source of future problems. So it was a really very unfortunate and day. I really had to ask for my colleague, urologist to operate on her and remove her kidney. So no women should reach to that stage. Whenever there is a problem, please investigate it thoroughly and do as I said, the transabdominal scan also has to be done, because kidneys also have to be looked at. We cannot just only look at the endometriomas, ovarian endometriomas, and say she has endometrioma, but we have to see about the ureter and kidneys as well. And this is a case of endometriosis in myomectomy scar. Endometriosis can be found anywhere. So this was a young girl, again, 25. She had a myomectomy done, and she presented with severe pain during periods. And we scanned her. We found that she has endometriosis in her myomectomy scar. So we have to be vigilant about endometriosis. It can be found anywhere in any form. And the very important thing we should look for is an ovarian mobility. How to look for ovarian mobility? Apply pressure with transvaginal probe to assess whether ovary is fixed to the uterus medially or the pelvic side wall laterally. Note any indication or site-specific pain. So this is a case where this is a clipping where we are checking about the mobility. You just put a little bit of a pressure on the suprapubic area, and if you see all the organs are moving together, means the sliding sign is absent. And if there are moving separate from each other, then the sliding sign is present. So assess the POD mobility, and it can be easily learned. It is not something very difficult. So uterus should slide anterior to the rectum, and then use free hand over abdomen wall to assess movement of the uterine fundus. And if no movement in either location, POD is recorded as obliterated. So this is a case, a positive sliding sign. You see always there is a little bit of fluid behind the uterus. And when you are pressing, this is moving very easily over the rectum. And you just have to follow the black line to assess the rectum, and you know that the sliding sign is present. And then absent sliding sign, look here, there are a lot of, you can see there's an adenomyotic uterus. If you see here that there is a heterogeneous myometrium, and there are nodules also in the uterus, and there is a negative sliding sign. Rectum and uterus move together as to separately the previous clip. So this is a absent sliding sign, and follow the black line to identify the rectum, and you know that the rectum is moving along with the uterus. So this is again the similar case with the absent sliding sign. Now you can identify even the adhesions. Many of you who are doing the pelvic scan might be seeing these flap-like things in the pelvic cavity. There is a little bit of fluid which get trapped between these adhesions, and this filmy adhesions have fluid entrapped, and that is called a flapping sail sign, and the uterus is fixed, that is a question mark sign. So this all can be picked up on a good scan. So this is a scan with a question mark sign. Fundus of uterus is pulled by the adhesion, and the uterus is fixed. And these are again a case where there are adhesions in the POD, which we have picked up on the scan, and we know that this is a deep invasive endometriosis, thickened uterosacral in POD in endometriosis. Now the checklist in endometriosis, you should check uterus mobility and adenomyosis. In the ovaries, check endometrioma and mobility, mobility of anterior compartment, mobility of posterior compartment, bladder, bowel endometriosis, and hydronephrosis. I mean, at times there can be malignant transformation of endometrioma, but which is not that great, 0.3 to 0.8%. And use simple rule to discriminate between benign and malignant cysts. Simple cysts are unilocular, and malignant are irregular solid cysts. MRI help in assessing area inaccessible to laparoscopy, but if you are doing a good ultrasound and you have a good ultrasound department or a good colleague who is doing a good endometriosis scan, you can really be helped by ultrasound, and MRI may be needed only in the cases if it is a recurrent case of endometriosis. There is an international terminology of for endometriosis. There's a very good article in a journal of Obs and Gynae, where you can go through this article and learn about this. And this is a systematic approach to sonographic evaluation of the pelvis in women with suspected endometriosis by IDEA, International Deep Endometriosis Analysis Group. And this is a paper by Matthew et al., in which they have explained detailed analysis of endometriosis by ultrasound. I think this is a subject in itself where one has to really do a good ultrasound or ask for an ultrasound, and you can really make good decision pre-operative for your patient. That is called a mapping of endometriosis pre-operatively to optimize your surgical outcome, and especially helping the women in counseling whenever you are operating. So take home message is transvaginal ultrasound is accurate at assessing endometriomas. Severity of symptoms does not correlate with extent of disease. Identifying an endometrioma, likely that there is further sites of pelvic endometriosis. Kissing ovaries associated with extensive pelvic adhesions. Adenomyosis is usually underreported, and assessment of pelvic mobility can indicate adhesion. So in nutshell, you can ask your colleague, if you are sending them for endometriosis scan, please look for all these things, because it will help me in making the surgical decisions and counseling the patient. To summarize imaging modality, with current improvement, high resolution scanning, it is now possible to diagnose most of endometriotic lesions, and addition of color Doppler helps in scoring and detecting endometriosis and differentiate it from malignancy. So thank you very much. And transvaginal sonography is accurate at assessing severe endometriosis when performed by experienced operator. So I think I'm done with endometriosis, and thank you very much for patience listening.
Thank you, Archana. That was a nice, comprehensive presentation. And very nicely, you had correlated the sonography findings with the laparoscopic findings. So I just wanted to ask one thing. I have a 16-year-old or a 14-year-old child with chronic abdominal pain. Every month she misses school. She can't have a transvaginal scan because she's so young. And the sonography repeatedly says it's a hemorrhagic cyst.
I know it's a very, very difficult question to answer, because you know what you have to do. Like, I'm sure she must have had a menarche, and she must be, that's why she's getting. So size of the cyst, if it is, you have to measure the size of the cyst during the menstruation and beyond the menstruation. So if during the menstruation,
I just wanted you to highlight on that. I wanted you to highlight on that about the timing of the ultrasound in a young adolescent girl.
Yes. So it is important that in adolescent, what you have to do, because it is very difficult to scan a young adolescent, because there is some kind of adiposity is always also there on their tummy. They may have other. So what you have to do, you have to scan them not during the menstruation, or call them twice. When she has a pain, measure it, and then when she doesn't have a pain, like in the you can say 14th-15th day of the cycle, you measure, and if you see that the size is different, then you know that it is most likely an endometriotic cyst, because hemorrhagic cyst you will usually get in the luteal phase of the cycle, not in a luteal phase or early menstrual phase, not in the follicular phase or late follicular phase.
Any other questions?
Good to see Dolly here.
Hello, ma'am. Good evening.
A very nice lecture and beautiful images, and you demonstrated the sliding sign also. Do you also look for probe tenderness, Archana?
Yes, that's a part of examination, because probe tenderness tells you a lot. And if there is a probe tenderness and you see the sliding sign, you know that there's a deep invasive endometriosis.
Dependent, because there is nothing like a quick ultrasound for pain. And I would urge all of us to emphasize on the courses. Like, there's so much about fetal medicine and there's so much about importance for the obstetric ultrasound. But I think somewhere we have a lot of quick ultrasounds done for pain. So the emphasis on a good gynecological ultrasound should be emphasized.
I think very beautiful point you have brought out, Meeta, that you should have focused thing, like focused. That is endometriosis, like, how you have separate clinics for early pregnancy scan. So I think gynec scans and most of the diagnosis of adnexal masses or endometriosis, anything should be done before you are putting your scope. So it's very important that we should focus. Now we should take it, Purnima, into our courses,
Definitely.
endometriomas and the gynecological scan need to be emphasized. There's nothing like, I'll just put a probe and I'll come back. No, we have to give a little time, spend some time, and come closer to the diagnosis.
And it's become very important to take the correct consent also. So if we have done a thorough scan, then we can take a consent for all the different procedures we might be doing.
That's very important.
In your experience, Archana, have you ever had to do a transrectal scan for a young girl?
Yes, we have to do. Once we had to do, because when they come with dysphagia, they come with dysphagia, and then people keep thinking there may be piles or there may be something. So you have to do a transrectal. I mean, what I do in a young girl when I'm scanning, I ask their parents, though, I mean, an obstetric scan, you can't have anybody else, but in young girls, because parents, it's important to take them into confidence and do a scan there.
To emphasize that
Yesterday only, I mean, I'm just going off. I had a 14-year-old girl presented with a little lump below her urethra, and she has had menarche at age of 13, and she's now 14. Mother says that this swelling under the urethra comes only during menstruation, and when menstruation finishes, it goes. So I scanned. I didn't put her picture. I think in the next sometime I'll put her picture in next lecture or so, that there's a beautiful endometriosis under the urethra in a 14-year-old girl.
My emphasis was only that sometimes a transrectal scan may be useful. And of course, MRI always remains a backup plan. Yes. Thank you. Thank you for a lovely presentation.
Thank you, Meeta, for being here and your useful, I mean, very, very useful inputs.
Thank you, Archana, for the wonderful discussion on endometriosis. Very valuable input from remark on
Dr. Anjum, your voice was breaking, I think. Dr. Manila, ma'am, can we have
you want to the panel now?
Yes.
Yeah, I think she asked Dr. Parikshit for comments if he's there.
Yes, sir. Yes. I think sir has.
Okay, I think you can move on. Yeah.
Yes. Can we have Dr. Manila, ma'am?
Can we have Manila ma'am speak, please? Thank you. I request Manila ma'am to introduce moderator for the presentation today. Now, regarding a few words, she has been the past president of the Obstetrics and Gynecology Society, also the joint AICOG. She has number of awards to her credit. She has been the professor of Department of Obstetrics and Gynecology at Mysore Medical College. She is now the director of Coral Hospital and Research Center at Manila. Ma'am, I welcome you and request you to introduce the moderator for today's session, Dr. Rupali Dharwadkar.
Thank you, Dr. Anju. It's my privilege to introduce Dr. Rupali Dharwadkar. She is a highly accomplished consultant obstetrician and gynecologist based in Mumbai. She holds multiple distinguished qualifications, including MRCOG and fellowship in IVF and trained from Nagori Institute. Currently, she is associated with renowned institutions, including Surya Mother and Child Care, Criticare Hospital, and BGCH Hospital. She has also served as an honorary consultant at BSEC Global Hospital. Beyond her clinical practice, Dr. Rupali is deeply engaged in the academic and mentoring field as an MRCOG mentor with MRCOG goal and an active member of West Zone AICC RCOG. We can see her commitment and dedication in organizing this webinar. And during this duration only, I got to know more about her. And I'm highly privileged to introduce her as a moderator to the panel. Looking forward for an interesting and a very deep discussion forward. So, Dr. Rupali, I welcome you.
Thank you, madam. Thank you so much.
I now welcome the panelists for the discussion. Can I have the first slide? We have a very interesting blend of gynecologists, IVF experts, and laparoscopic experts. I would like to introduce the first panelist for today's evening, Dr. Aarthi Santosh. She is presently senior consultant at Narayana Super Speciality Hospital in Mysore. And she has undergone training in laparoscopy at Sunrise Hospital. She has also completed her cosmetic gynecology masters and an MBA in hospital management from BITS Pilani. Welcome, Dr. Aarthi. Our second panelist for today's evening is Dr. Yasmin Imdad. Yasmin Imdad is BPO MRCOG and she has also completed her MRCPI. She is presently consultant at Kindra Hospital and she's also running, she's director and chief mentor for her MRCOG training. She has interest in high-risk pregnancy and has led the high-risk pregnancy clinic in the Brunei Ministry of Health. I welcome you, Dr. Yasmin. Regarding Dr. Dolly Mehra, ma'am, so she has been president of Ratlam Mouse Gynecology Society. I had the privilege to work under her. As a president, we could perform very well at the national level as a society and won a number of awards under her presidency. And also, even with a busy practice, she has recently cleared her MRCOG Part 2 and congratulations on that. She has a number of publications to her name, as well as she has been a faculty at national and state conferences. I welcome you, ma'am. We have the CV of Dr. Priya Patil. I welcome Dr. Priya Patil, who is the Master of Ceremony today, to welcome the other panelists for today's discussion. Dr. Priya is the MS MRCOG, and she has a number of awards to her credit, also publications in national and international journals. She is the teaching faculty in AAGL and RGHS recognized MIS training program. Dr. Priya, I request you to introduce our remaining panel for today.
Yes, thank you. It would be my pleasure. I would like to introduce Dr. Yasmin Imdad. She is MBBS DGO and DNB and MRCOG and MRCPI from Ireland and has done her fellowship in IVF, is a consultant obstetrician, gynecologist and fertility specialist. She has over 24 years of experience in India and Brunei, specializing in high-risk pregnancies, infertility, laparoscopic surgery and assisted reproductive technology. She is also an experienced speaker and CME panelist with a strong record in clinical practice and training. She currently is working as a senior consultant in Kinder Women's Hospital and Fertility Center, Bangalore. Her areas of expertise are high-risk obstetrics, infertility management and IVF, minimal accessible surgery, obstetric and gynecological ultrasound, CME presentation and academic mentorship. She's also set up and managed IVF services in Brunei and India and has been invited as speaker in multiple CMEs and international conferences. I welcome you, ma'am. Next, I would like to invite Dr. Aarthi Santosh.
No, Dr. Priya, start from Vaishali, ma'am.
Okay. I would like to introduce Dr. Vaishali Joshi, ma'am, who is FRCOG, MD, DNB, DGO, and FCPS, European Diploma in Operative Laparoscopy, and BSCCP accreditation from UK. She is a senior consultant in obstetrics and gynecology in Kokila Bain Hospital, Mumbai. She's completed her specialist training from London in 2012. She also holds a fellowship of Royal College of Obstetrics and Gynecology from September 2017. She is specialist in advanced labor ward management, high-risk pregnancy and gynecological endoscopy surgery and robotic surgery. I welcome you, ma'am.
Thank you.
One of our other panelists for today is Dr. Harinath. Dr. Harinath has completed his MBBS, DGO, DNB, and FMIS and FRM. He's a consultant chief surgeon in the Department of Gynecology in Cloud9 Hospitals. He also is a minimum.
Sorry, I think some technical issues. Harinab sir is faculty in fellowship in minimal invasive surgery at West Institute, and he has a fellowship in reproductive medicine as well. His areas of interest are complex hysterectomy and myomectomy, endometriosis surgeries, which is of course the topic for today's panel. So,
thank you.
Introducing our other for today.
Hello, I'm sorry, my
take over, Priya.
Connection got.
Please introduce.
Dr. Ashish.
Dr. Priya, you are not audible. Dr. Anjum, take over.
Sir is a renowned fertility and IVF endoscopy specialist, having experience of almost 29 years. He is the director at Dr. Dharwadkar Hospital and Anmol Fertility Center. He is also consultant at Surya Hospital. And, his experience will really help us with the panel discussion today. Welcome you, sir. Last panelist for today's evening, Dr. Anupama Patil. She has been my senior during my MBBS. She is consultant in infertility and reproductive medicine, having done her infertility training at Milan, Bangalore. She is running her own infertility center at Gadak. And her area of interest is interesting, which is low-cost fertility treatment, along with ultrasound in infertility and endoscopic surgery. I welcome you, Dr. Anupama. Dr. Rupali, I hand over the session to you to start with the panel discussion.
Yes, we have the chairpersons for our panel today, Dr. Meeta R Nakhare, Madam, as well as Dr. Parikshit Tank, sir. Can we please have your seats? Dr. Parikshit Tank has joined, right?
I've seen sir's name in the list.
Yeah, I can't see him.
I can see the name.
Yes, sir. Okay, Dr. Parikshit Tank, sir, is really very well renowned, and he's a academician. He has been our lecturer and has been a wonderful person as well. He's a practicing gynecologist and obstetrician in Mumbai. He has to his affiliations. He was the Deputy Secretary General of FOX as well, and he has many awards and publications to his credit as well. Welcome, sir. We are very happy to have you on board today. Can we have Dr. Meeta, ma'am? Meeta, ma'am, Dr. Anjum, can you introduce, madam?
Yeah. The chairperson for this session.
Anjum.
Anybody can be proud of. She has been in the medical field for over 30 years and is an alumnus of BJP. And after super specialization in field of women's health, she has practiced in India as well. She has number of awards to her credit along with number of posts. She is currently advisory consultant to 2 USA-based multinational companies and working with NGOs. It's very interesting. And Madam has been part of Ethics Committee of International Research on Stem Cells and on board of trustees for NGO and Institute of Women. Has fellowship in menopause, HRT, gynecology, and high-risk pregnancy. I welcome you, ma'am, as a chairperson for this session.
Thank you. So we start with our panel discussion today. The topic is endometriosis, the recent advances and the guidelines. We're trying to have a very practical-based approach to 4 cases which we have come up with. Can you, Sudeep sir, can you please allow the screen share?
You can share, ma'am.
Okay. The share screen option. Can you do? Yeah, one sec. I got it.
I request everyone other than the panelists to mute themselves, please.
Is the screen seen?
Yes.
One second. Is the screen seen, ma'am?
Yes, yes. Now it is in slideshow mode. Go ahead.
Okay. So we have the panel today here. So we know that endometriosis, nearly 10% of women of all reproductive age groups suffer from endometriosis, and it's quite devastating thing to have this. So today's our main objectives would be to go for evidence-based practices, timely identification, to do the fertility preservation in the relevant cases. What are the hormone-based strategies for recurrence prevention? And what would be the best surgical management for endometriosis and menopause and endometriosis? So we go for our first case. She's a 19-year-old who's unmarried, but she's sexually active, and she has complaints of dysmenorrhea since menarche. But she has become intolerable those symptoms, and she has to miss her school. She complains of dyspareunia too. Her periods are regular. She has taken routine painkillers, but she has no relief. Her mother also suffered from endometriosis and finally had to undergo hysterectomy. Her USG findings, transvaginal, which were done for normal. So, Dr. Aarthi, can you just help me with what relevant information in the history part you can think of, which is a pointer to the diagnosis of endometriosis?
Good evening, everyone. First is the severe dysmenorrhea. According for this question, the severe dysmenorrhea which doesn't get subsided with your routine painkillers. She doesn't have any relief. That one thing. There is a family history. Usually, when the parents, mother has, there may be genetical cause also. So that will be the second one. And dyspareunia with her complaints. So these all point out that she can have some nodules or endometriotic nodules. So that's the one information you will be getting it from the history.
Yes, the family history plays an important role in this patient. Instead of having a normal, yes, we see that they have dysmenorrhea intolerable, and the painkillers are not responding to painkillers. So we have to keep this in mind and move forward to investigate her. So far as investigation is concerned, Dr. Rupali, can you tell me what kind of investigations would you go for once we TVS are normal?
Okay, once her TVS is normal, I would like to go for, because it is not relieved by her simple painkillers, I would have started her with a presumptive treatment with continuous OC pills. Even if it is not relieved, even with continuous OC pills, then I would go for an MRI.
Okay. Is there anything other than a transvaginal scan or an MRI? Do you think of doing a transrectal?
Transrectal, transperineal, transabdominal scans are also available.
Anything 3D ultrasound?
Sorry?
3D ultrasound?
3D ultrasound, most of our uterine anomalies, good 2D transvaginal scan is good enough to pick up endometriosis. We don't need 3D for endometriosis. Maybe because if she has any obstructive uterine anomalies, like a transverse vaginal septum or non-communicating uterine horns, maybe, which may be one of the causative factors for her early endometriosis. That may be picked up with a 3D scan.
Okay. So now we know that the clinical history is a pointer to the diagnosis of endometriosis. We've done a transvaginal scan, which is normal, and and wants to give her a trial of an OC pill, which would be the first line of management. So do we also do a CA-125, Dr. Vaishnav? You do a CA-125 in this patient?
So, practically speaking, CA-125 doesn't have that much sensitivity or specificity. As per guidelines, it is not indicated, and it really doesn't tell us anything about the active disease or past disease. It will unnecessarily increase the anxiety, and that's the reason I wouldn't be doing CA-125 in this patient.
Okay. So we have investigated the patient enough. Dr. Yasmin, can you tell me, in this patient, what would be the first line of treatment which you would think of? Because in endometriosis, we have OC, progestin, GnRH, n number of things. So what is the first line of treatment which you would think of going for this patient?
So for this patient, depending upon her symptoms, so what I would feel is best will be the pain relief. That will be the first line. So we have different painkillers like the NSAIDs and all. Then because only painkiller might not be sufficient, we need to think something about the hormonal pills also. So we have to go with the combined oral contraceptive pills and the progestogens, because they are the most safest of all this. And nowadays we have the newer tablets coming up like the GnRH antagonist as well as or agonist, because that also reasonably can be used for a pretty long period of time without any side effects. So these are the usually medical management will be the first line of treatment for this patient.
Okay, thank you. Dr. Ashish sir, what would be your medical management for this patient? We have given her OC pills. She has tried progestogens, which were the first line of treatment. This patient has not responded to them. What
So
would
if she is not responded to this, then one can try with elagolix. Also nowadays you get a product called it is called as a combination of estradiol with norethistone. It's suggested in the NHS, relugolix. This may be tried. Beside this, of course, we can give her GnRH agonists also. Yeah, these would be the kind of things. I would not really suggest levonorgestrel because that can cause fertility issues later. But these are the things which we can suggest if OC pills have not worked or progestins only pills have not worked.
Okay. So you start with we come back to the OC pills. Would a continuous OC pill be better than a cyclical? What is the panel? Anyone can take that question.
I think the
better than cyclical.
I think the evidence says the both cyclical and continuous have a similar symptom relief, particularly pain relief, dyspareunia. But in my practice, and there are some studies which have shown that if you use the continuous type OC pills, that gives a more significant pain relief, and is patient can take it for longer, though there are some side effects like patient may get breakthrough bleeding after some time, so that's the only thing, but the patient can be kept on long-term continuous OC pills with a good symptomatic relief.
Okay, so we know that even the evidence, extra evidence and everything tells us that OC pills as well as progesterones, they can be used as a first line of treatment. We know that OC continuous would be better than cyclical. OC pills also they give us symptom relief, but we know that we will not stop the progression of the disease. And again, so far as progesterones are concerned, nothing is none is superior to the other. That's what the guidelines tell us. Now, moving further about these GnRH agonists. So, anyone who would think that if OC pill and progesterones have not worked, then would you think of doing an LNG-IUS in this patient since she is a sexually active patient, or go for a GnRH agonist? Can anyone from the panelists take this question?
I wouldn't.
The fact that please.
IUS, if she maintains her hygiene, can be used. It will be acting as a contraceptive also for her. So it can be useful, and daily she need not remember to take her pills. So it is a good option for her since she is sexually active. GnRH agonist in an adolescent can cause bone marrow depletion. So unless we give an add-back therapy for adolescents, it is not a very good option, especially if we are continuing for more than 6 months. Because this is a long-term treatment she will need. She may need for more than 6 months. So GnRH agonist may not be a good option for her, especially in an adolescent.
Yeah, so basically she's just 19 or 20 years of age and she's likely to have endometriosis for a long time. So
Yes.
sometime or the other, we'll have to keep changing these modalities of treatment.
Correct.
One to the other, and basically supporting her and counseling.
Okay.
Preservation also.
Yes.
But I think this Myrina can be given as an option. You don't know if it works for her. That will take her a long way, and she can avoid all other side effects. Though with add back hormone replacement with GnRH antagonist, one can go on for very long time. But looking at her times lifespan and reproductive lifespan, I think there is a worth trying IUS.
What the guidelines do tell us is that when the first line is OC pill as well as progesterone, if they don't work, then we can go for, if she's sexually active, we can go for a Mirena. Otherwise, the second line would be a GnRH agonist. And of course, the GnRH agonist cannot be given, as we say, like, if she's below 18 years of age. The patient has to be above 18 years of age so that we can start a GnRH agonist. And of course, with an add-back therapy, that is very important.
The oral antagonists available now, they claim that the bone marrow depletion is not much with them and can be given for a long time.
Yes, that is also a thing which we can figure in. Now, I want Dr. Harinath sir here to tell me that this patient, we have tried everything and still she's not getting relief. Would you like to think about a laparoscopy in this patient because you're not having any indication whatsoever on a ultrasound or anywhere, but her dysmenorrhea and dyspareunia have not been responded as much and she's still missing her school. So what would be the indication to do or put in a laparoscope in this patient?
Like now, as all of you have said, there is no positive finding which has been documented on scan or an MRI, and your first line, second line medications have not been able to give her symptom relief. I think she will be a candidate who can undergo a laparoscopic procedure, not just a diagnostic, but also as an confirmatory or a operative procedure is. Second thing is like, see, since we are talking of endometriosis, let us not confine ourselves to only endometriosis. Since she is sexually active, there is an element of PID that can coexist. And always examination gives the best result. I think no matter whatever investigation we do, I think a very detailed, thorough examination in the OPD per se will give you more findings, almost equivalent to what your scan and other findings. So definitely we can do in a laparoscopy, but the challenge is with all the findings being negative and that laparoscopy being the only option, convincing the patient's parents is a challenge there. Other than that, doing a laparoscopic procedure definitely adds value because at least we are moving towards making sure that we are ruling out endometriosis, and we also would look at other pathology that may be coexisting where either the MRI or an ultrasound might not have picked up, and that could be corrected during the procedure.
Yes,
So
right.
a laparoscopy would be helpful.
Yes, very rightly said. Even the ESHRE guidelines also tell us that once we do a laparoscopy and it is confirmed that it's come out as an endometriosis, then for the second prevention of the endometriosis associated dysmenorrhea, a post-operative use of an LNG can be done. This is what the
The other
ESHRE.
thing is, you may not see a obvious finding of endometriosis. So in that situation, it is better you take multiple peritoneal biopsies from suspicious lesion or from especially the uterosacral area, POD, ovarian fossa, and pelvic peritoneum. At multiple places, you can just inject dilute vasopressin, create a blood band with a scissor. You can excise few peritoneal lesions and then take it and check for histopathological examination. In spite of histopathological examination still not able to pick up endometriosis, doesn't mean that endometriosis is not there. There still can be some foci which is not picked up, and that also is possible. But at least we are more sure that the level of symptoms and the level of the disease may not be correlating in her. That's very important for the counseling part.
Yes. So if we go, thank you, sir. Now, if we go for elagolix of the GnRH antagonists, what this is in general, not just for this is a adolescent patient, but this patient was say 25, 30 years of age. Then, Dr. Anupama, could you tell me that what would be the indications for the GnRH antagonists?
I couldn't hear, please.
Dr. Anupama, my question is, take this. This is not a patient which we are discussing right now. This is in general a patient of 25 years who has come with a diagnosis of endometriosis, and we are contemplating starting a antagonist, GnRH antagonist for her. So, what would be your indications to start an antagonist from her?
If pain relief is her prime goal now, then I would start her with an antagonist, but I would prefer a long-acting GnRH agonist than daily tablets. But if she has to take for a long time, then maybe an antagonist will be okay. If she has not, I would still go for a progesterone, which is or aromatase inhibitors also I would consider. And also about her fertility, I would be concerned. What is her AMH level? Is there an ovarian endometrioma? All those also have to keep in mind because she's in the reproductive age group. She has not completed her family. So what is her primary goal, whether it is pain relief or fertility, I would discuss with her and take a decision.
Yes,
so antagonist is just coming up. We have just started for some patients and they're responding well. But my first drug of choice will be a progesterone.
Yes.
Long-acting progesterones or a long-acting GnRH agonist.
Exactly. So you've really answered it well that GnRH antagonist could be a second-line treatment for endometriosis-related pelvic pain in those cases where the pelvic pain is there in spite of trying NSAIDs, ocipils, progesterone, or where there is a progesterone-resistant disease, or where patients are really bad but they seek a non-surgical option. The contraindications, it's just to complete the list. We all know that pregnancy, osteoporosis, severe hepatic impairment, and some concomitant use of some medicines like cyclosporine, statins, and gemfibrozil. The dosage.
One more thing is,
yes,
in the slide it was written as patient seeking non-surgical option. So whatever is the disease, is if the patient is not willing for surgery, so does it mean that elagolix can be started?
We can try that and see, no, sir. We have to give something to the patient, and GnRH antagonists may work in those patients.
And one more thing, it is after all patient's choices, informed decisions. If patient has to decide.
Yeah, I understand.
Surgeon sir wouldn't like to hear that, but
no. I'm surgeon, but doesn't mean that I operate everyone. I'm just curiously, this last line was a little curious for me. Like, no matter whatever is the size, 10 centimeter, 12 centimeter size, okay, patient is not willing. You can try elagolix and.
No, sir. This would be a second-line treatment for endometriosis-related pelvic pain.
Pain.
Yeah, when pain is the main factor, and then that is a time when not when there is an obvious endometrioma or a huge endometrioma, but deep infiltrating, but endometriosis, definitely.
Yeah, no problem.
Yeah. The dosages which we would go for an antagonist, if you start with 150 mg once daily, and then 200 milligrams twice daily for 6 months, it should associated dyspareunia is also there. Now, so kind of gone through the whole thing. And to summarize, adolescent endometriosis, if we have to kind of come to a diagnosis, we know that the symptoms of this endometriosis in adolescents, we could take a detailed history, a chronic acyclical pelvic pain, whether she's having dysmenorrhea, dysmenorrhea, dyspareunia, and a careful history, obviously, in all the diseases, as much as this goes a long way in coming to a diagnosis, initial diagnosis, differential diagnosis. A transvaginal scan, an MRI, transabdominal, transperineal, transrectal can be considered. A CT scan does not really have any value out here. K125, as Dr. Vaishali rightly said, that it's not recommended. And in FOXY guideline, it was just theoretical. It was given that a salivary microRNA was being validated. And as Dr. Harimat also said, that where the imaging is negative and medical treatments have not been successful, then diagnostic laparoscopy may be considered. So we are now knowing how to handle an adolescent endometriosis patient who walks in to take treatment from us. So moving on to my second case. Okay, even in this patient, if she is 25-year-old, I would like Dr. Dolly, would you tell me something about fertility preservation if this patient was a 30 years old and who has come with endometriosis?
Yeah, it's very important that, these adolescent girls, we have to take care of three things. First of all, we have to manage their symptoms. We have to avoid the disease progression, as well as take care of their fertility preservation. So, it is better to treat these girls on the oral contraceptive as mentioned. We can also try you can give OCPs for 3 cycles and then withdrawal after 3 months. That would be a better thing for these patients. LNG IUS, if the patient has undergone a laparoscopy to confirm the endometriosis, we can use LNG IUS to preserve her fertility. And in case if the diagnostic laparoscopy has been done, it is important to excise the cyst wall rather than just the ablation of the endometrioma if it was there.
Yes.
These cases, we have to particularly keep an eye on the Mullerian anomalies as well, which can be missed by a normal 2D ultrasound. So we can go ahead with a 3D ultrasound or a rectal ultrasound, which will be very important. And also, if we really think that this patient may require something called as the ovum preservation, that also should be considered because this is a disease which is going to progress.
Correct. Very true. Very true. So she was a 30-year-old and she's come with endometriosis. We also in certain cases use aromatase inhibitors. Does anyone on the panel use them? And if so, for any particular indication?
We use extensively aromatase inhibitor, letrozole, especially for adenomyosis. We use it for triple down regulation with a GnRH analog, progesterone, and aromatase inhibitor. This works very well for adenomyosis just before embryo transfer. We give it for 2 to 3 months. But for endometriosis, we don't use much because there we try to do the egg retrieval, freeze the embryos, then go for surgery, and then the embryo transfer. But in adenomyosis, diffuse adenomyosis especially, we give letrozole for 2 to 3 months continuously along with the progesterone and GnRH analog. We call it as triple down regulation.
Thank you, ma'am. The HLA guidelines do tell us that we can use aromatase inhibitors, especially in rectovaginal, surgery-resistant rectovaginal endometriosis cases also. But the NICE guidelines do not advise us for that. Even the ASRM guidelines also not permit us to use the letros and anastrozole.
This is not FDA approved in those countries.
Yes, it's not FDA approved. So this is something. Okay, so we move on to our next case. The next case is a case of an endometrioma with infertility. She's 30-year-old. She's primary infertility. She's come with a 4-centimeter unilateral endometrioma. She's trying to conceive since 2 years. Mild dysmenorrhea, no dyspareunia, regular cycles. HSG showing bilateral pancreatic semen analysis is normal. Her serum AMH level is 3.5. Her concern is to get pregnant as early as possible. So we are here today to discuss what would be the best management for her and how do we go about this. So, sir, can I ask you this question? Is surgery effective to conceive naturally?
Is surgery effective in conceiving naturally?
Yes, Dr. Ashish, sir. Dr. Parekar, sir.
So I think in this patient who is married since 2 years, she's trying and she's about 30. And if her husband's semen analysis is normal,
yes,
then definitely she should go for a laparoscopy. And laparoscopy, if done very well in the first time, This cyst, if it is removed and the oocytes conserved as much as possible, and then this can definitely help her to conceive naturally. Her tubes are also open, and obviously if the tubo-ovarian relationship is also normal, then a good surgery done can help her to get pregnant naturally. Yes.
So even for a 4 centimeter endometrioma, you would initially think of excising the endometrium, then going for the rest of the treatment.
Yeah, definitely. The endometrioma can be excised, the cyst lining can be removed, and if all the things are normal, that is, her tubo-ovarian relationship is normal, tubes are patent, her husband's semen analysis is good, they have a proper coital frequency, then definitely I would, and her AMH also is good here. And obviously, I would do a AMH post-op also. And if it is good, then we can definitely give her some trial. And if not, then of course go on to other modalities like IUI, etc.
So
Yeah,
rightly,
but she can conceive naturally. Yeah.
sir, you rightly said that the decision to perform the surgery will be guided by these following factors: whether her pain symptoms, how severe are the pain symptoms, what is her age, is there any history of any previous surgery, are there any other associated infertility factors or AMH value of previous. And we should also have a good counseling session for these patients because we have to tell them about the risks of reduced ovarian function after surgery and the possibility of loss of ovarian reserve as well. So, Dr. Yasmin, would you always routinely consider doing a surgery before any assisted reproductive technology? Dr. Yasmin? Any of the panelists can take this question.
Yeah, I'm there.
Yeah, Dr. Yasmin, please tell. Would you routinely recommend a surgery before any artificial reproductive technology? You're thinking of taking a patient for, say, IUI, IVC, etc. But would you routinely recommend a surgery in this patient?
Usually, I would not routinely recommend any surgery because, like, considering there will be like ovarian tissue loss will be there after surgery. So that's why I would try to first go ahead with ART only. My first choice will be depending upon like how soon she wants to conceive. Maybe we can do IUI, or if it is like very urgent, then other modalities like IVF. But definitely not surgery at this point of time because, like fertility is my utmost, and her tubes are patent. AMH is also good, and 4 centimeter endometrioma is also okay because if you can do pickup also, that is also okay. So this ART is the best modality actually for her.
Okay, so as you rightly said, we do not recommend, guidelines also do tell us that we only recommend a surgery prior to an ART because of the reduced ovarian reserve. The response to ovarian stimulation later on could be lower. The use of higher gonadotropins in the ART cycle and the less number of oocytes which are retrieved. Now, only cases, there are some cases where a surgery prior to an ART, as Dr. Parikshit sir said, would be considered when there could be a rapid growth of the cyst, any suspicious features, potential for rupture during pregnancy, and severe pain or non-accessibility of follicles during the open pickup. So, Dr. Harinath sir, I would just want to ask you, patient has come, she's asymptomatic, tried everything, but she wants infertility. Would you remove any uncomplicated deep endometriotic lesions once you have put in a laparoscope? And you happen to do laparoscopy for some other reason, but you see some deep endometriotic lesions. Would you remove them?
See, the thing is, other indications you are operating and you are incidentally finding some DIE lesions.
Yes.
If the patient is really asymptomatic, it's not to be touched unless until, see, there are certain scenarios where if the surgeon is confident enough to comfortably remove them and without any complications, then it can be discussed, but I'm not really sure if it has to be really touched upon since they're asymptomatic.
Yes,
But
yes, that
there is another situation where you, after you don't do anything, another 3 to 6 months time, if she ends up developing symptoms, then why was it not done at that moment? Question also would arise. But I think a good counseling with the patient and the relatives is
Yes.
very important.
That's exactly the question. We are in a dilemma most of the time. But this is what our guidelines say that, if she's an asymptomatic domina or if she's symptomatic but not seeking conception when the medical treatment is effective and well tolerated, then we should not remove the complicated deep endometriotic regions which are incidentally seen when we do a laparoscopy for some other reason. This is what was the point which I was trying
Can
to.
I add, ma'am?
Yes, sure.
We routinely encounter such dilemmatic situations, but unless we have counseled pre-operative about the presence of deep endometriosis and the rectal shaving and the other discoid excision involved, we cannot take a decision on table to do any surgeries which was not explained to the couple before surgery. So if we
Agreed.
have not done the counseling before surgery, we cannot touch intraop even though he's a good surgeon. And if it was diagnosed pre-op by a good scan, then we can counsel, and removal of deep endometriosis will definitely improve her pregnancy chances.
Exactly. Absolutely.
The other thing in this question is if the question itself is modified, if you are doing a diagnostic hysterolaparoscopy for an infertile woman where on ultrasound no lesion was picked up, and incidentally you are operating for some other indication where you see an endometriotic lesion like a peritoneal implant or a puckering or some nodule, then definitely go and remove it even though it is asymptomatic, because that can lead to another pathology in the future if you have counseled them. Yes. And the first thing which I have been learned and practicing is endometriosis, if you see in an early stage, even if it's a small implant, don't come just saying that it's a small implant, it's okay. Better to excise or ablate it, though that peritoneal lesion may not be the symptom factor or maybe a direct causal factor, especially with endometriosis. DIE, whatever your question is correct, don't unnecessarily handle.
Correct.
But when you come across with a peritoneal disease or a superficial endometriotic lesion, then better to handle.
Yeah, as it is. Otherwise, you'll face the music after 6 months.
And one more thing, medico-legally also we should be take up without a consent. How can that also will come? No, if the patient lands up, if everything goes fine, okay. But if there is a complication, that also we
this
should
point
be.
is the fertility specialist or the surgeon operating should thoroughly counsel the patient that if in case there is a lesion which is not picked up on an ultrasound, definitely we will go and do it. Again, the surgeon's counseling is very, very important before, and we won't do any surgery without any consent. So there's no doubt about consent or medico legal. No surgeon will handle any case without taking consent. I don't think anybody would do such thing, even if their own relative. I don't think we would do such a procedure. So
that point is well taken. That point is well taken. We come to Dr. Vaishali. Can you tell me which patients need an reproductive techniques, whatever, for surgery?
Sorry, I could not hear. Can you repeat?
Yeah, so we have done a laparoscopy in a patient. And so which category of patients will you decide that, yes, now we've done a laparoscopy. Now this patient, or some patients after laparoscopy, we see that she can go for non-natural cycles. But some other patients, we know that they definitely have to go for some hard procedure. So which are those patients? This is what is happening.
Yeah, so as per the guideline, they have this new thing that they have developed, the endometriosis EFI, endometriosis fertility index, which kind of help the clinician and the patient also to make a care plan post surgery. It includes the number of years of infertility, then the involvement of the both the ovaries, the endometriomas. Then also it depends on whether what is the AMH level. So if the AMH and what surgery you have done on the ovaries. So depending on if EFI is high, then there is a very good chance that she can try and wait for natural conception post surgery. But if AFI is low, or if there is a long history of infertility, and if there are multiple other cofactors contributing to subfertility, then she would be ideal candidate for ART.
Absolutely. Perfectly. Great. Very nicely answered, ma'am. Thank you so much. That I really don't need to put anything more in this. So we move on to Dr. Ashish, sir. Now, which patients of endometriosis do you think would need an IVF or an ICSI?
So basically, patients who are more maternal age, the AMH is less. They've had already many cycles of IUI and they have failed. During the laparoscopy, which you did if the tuber-ovarian relationship is not normal, or if there's a male factor associated with the endometriosis in the women, and even those women with very moderate or maybe severe endometriosis of age more than 34 or 35.
Okay. So we know now that we have decided that this patient, we have done a laparoscopy, everything. Now we know we have decided that we are going to go for an IVF or an ICSI for this patient. So Dr. Dolly, can you just tell me which stimulation protocol would you think is the ideal, or is there, because she has endometriosis, you would prefer one over the other?
See, first of all, in the surgical aspect, I would like to just comment upon there is now a technique available wherein you collect the ova first, then you operate the patient, and then the patient undergoes the ART cycles. That is the best method because at that time the ovarian reserve loss will be less.
Okay.
And because these patients, they are already, at the risk of poor ovarian reserve, I think a GnRH antagonist cycle would be a better than a agonist cycle.
Okay.
Can I add to it, please?
Yes, anyone has a difference of opinion here regarding protocols?
Yeah, as Madam said, first we have to assess whether the follicles are easily accessible. So if they're easily accessible, then we can go for oocyte pickup first, followed by surgery and then embryo transfer. But if there is a large endometrioma which may come in the way of the egg pickup, and we may inadvertently puncture that and lead to complications, then a surgery would be first. So, and regarding the protocol, a long agonist or an antagonist can be picked up. Only advantage with the long agonist is we may get 1 or 2 oocytes extra, which may be very helpful in these patients who already have a low reserve. So, but antagonist is also equally good. But we'll have one extra oocyte, even progesterone primed ovarian stimulation can be done. So, all these are the protocol, even dual stimulation for that matter can be done. So these are some of the protocols. All the protocols are applicable to this. Depending upon the follicle sizes on day 2, day 3, we can choose. If there is a very wide variation in the follicle sizes, then we can go for long agonist protocol or estrogen giving pre-stimulation to make the follicle synchronous, or do an anti protocol. Depending upon the follicle sizes on day 2, day 3, we can select the protocol.
Thank you, madam. Thank you very much. What the guidelines say is that since there is no difference in the pregnancy and the live birth rates for an FET or GnRH antagonist or an agonist protocol can be offered to the patient depending on the patient's reserve, whether AMH or AXC count, etc. Obviously, during an oocyte retrieval and antibiotic prophylaxis, as we all give otherwise, also can be considered in women with endometrioma because of the risk of ovarian abscess formations. So anyone wants to add anything in this infertility case, especially Dr. Ashish sir, because you're doing IVF and ICSI day in and day out. Is there anything which you would like?
No, not really.
Dr. Parikshit has joined. Since sir is doing IVF, I wanted his
pricking these endometriomas. And the other challenge will be adherent ovary. Sometimes we'll have to go through the uterus also sometimes to pick up, especially if it's a posterior adherent ovary. Sometimes the pickup needle may have to go through the uterus to pick up the follicles. So these are slightly difficult cases, and we should avoid puncturing the endometrioma. If we have punctured, then a thorough flushing of the needle will be required, or changing of the needle will be required, and good post-operative antibiotics. Avoid pricking the endometrioma.
What is the role of aspiration per se for a endometrioma to avoid a surgery? How is it?
Aspiration followed by sclerotherapy can be tried, sir.
Do we have Dr. Parikshit sir? Dr. Parikshit sir is not there. He is not joined. Dr. Parikshit sir is there? Okay. So Dr. Meeta, ma'am, is there? Dr. Meeta Nakhare, ma'am. Hello. Yes, ma'am.
No, I quite agree with what is being said.
I just want input from both these cases which we have discussed.
I think you sort of covered up everything, and like Archana has said before, endometriosis needs to be not small, medium, large, but treated on an individual basis to what that patient needs. So the guidelines to make sure it's clear to everybody. But
Yes.
for endometriosis, as we all know, we have to take the treatment case-based.
Yes.
Just because we cannot the guidelines, what you're doing is a great job, because we're sort of going through the guidelines and making sure we're not doing anything too hastily and
Exactly.
sticking to the guidelines, but the protocols seem fine.
Yeah. Thank you. So we move on to our third case. She is a 50-year-old. Here we are going to tackle a menopause patient. She's 50-year-old. She's para-2 living through with previous 2 cesareans. She has come to an emergency with a severe lower abdominal pain, and her transvaginal scan showed an endometriotic cyst which was 2.5 by 2.8. This is a big endometriotic cyst here, but this is what was seen. She has attained her menopause. So in such kind of a scenario, what would be, Dr. Yasmin, can you take that? What would be her differential diagnosis which would first come to your mind?
Yeah, first of all, as the TVS has shown, endometriosis is one. Then it can be some benign ovarian cyst other than endometriosis. Even it can be malignancy because the patient came with severe lower abdominal pain. Or it can be some adhesions related to the previous 2 cesareans she had. Or it can be, in fact, some GI pathology also. So these are the various options which we should keep in mind while considering a diagnosis.
Okay, so once we have, how would you come to a conclusion? Would you do a CA-125 in this patient?
CA-125 usually is not diagnostic, but it can just be like a adjunct only in the treatment for her. But still we will do.
Because it's a menopausal patient who is post-menopause, who's coming with a cyst in the ovary, so we are justified in doing a CA-125 to rule out a malignancy.
I think the Roma test is a better test, particularly because HE4 and a CA-125 with a menopause factor, so it has a more sensitivity to pick up. Those specificity is not very, very high, but that's what I would prefer doing it. And I think mostly it's very unlikely the endometriotic cyst to tort or undergo any kind of ovarian cyst accident. So maybe I think we should look at whether it is a renal colic, or as Dr. Yasmin said, whether there is a GI cause. So that's the main first thing will come in my mind, that we should rule out the acute cause of a pain.
Okay, so here we have the Roma index, which is not really very, telling us a conclusion of a malignancy. But this patient has come to an emergency. We have given her injection. She has settled down. Now, would you think of a medical management for her, or would you opt for a surgical management for a menopausal patient? Dr. Anupama?
Yeah, menopausal women with endometriosis is an indication for surgery, because the chances of malignancy can be as high as 30 to 40%. So I would do a MRI first and then go for surgery. No role of medical management in a postmenopausal lady with endometriosis.
Agreed.
I would like to say something.
Yes.
We can calculate the RMI score, and in these patients, because the size of the cyst is less than 4 centimeter, or rather 5 centimeter, the only thing is that she has pain. Otherwise, if she's asymptomatic, we can wait for another 4 to 6 months, evaluate her again, and then go in for a surgery. But here, because she's symptomatic, we may consider surgery first.
So if the patient is having this 3 centimeter cyst and if she's not having any symptoms,
then
and
we
if
can just wait.
If her index is Okay, so we can still wait on this.
Ma'am, the other thing which I want to put across is it's not just the size of the endometrioma. Always do a thorough Doppler study of the lesion, because recently, just 2 or 3 weeks back, we faced a scenario where a patient who was a known case of endometriosis had one child. 38-year-old lady came with for a second wanting to have a second baby, now with an endometriotic cyst. Our TVS scan showed that there is an endometriotic cyst below which there is a solid lesion with moderate vascularity on Doppler. So we did all the markers. All the markers are normal. We did an MRI also in a very reputed, very good center itself, in a very good by a good doctor. They said whatever that solid lesion you are seeing below the cystic lesion is the normal ovarian tissue. So even with a pinch of salt, we explained to the patient that the scenario is very dilemmatic and you have to go in for a surgery, but if need arise, if there is a suspicion of malignancy, then things will be a little different. And when I went in, I took out the cystic lesion. Just below the cystic lesion, I could actually, as soon as I gave a neck, I could see that solid papillary lesion which was there. And then we had to convert it from a robotic to a lab, do a adnexectomy, send it for frozen, which came as endometrioid adenocarcinoma in a 38-year-old lady. So I think a Doppler is sometimes missed, or probably not just the size or is going to make a difference. It is the thorough evaluation. I think a good sonologist should be doing it, and then only we can take a call.
Okay. So if we know that the surgery is not feasible for whatever symptoms, or because the endometrioma was a small one, but my index is showing that it's not malignant, then if we think of medical management, what are the which we can think of to give for this patient? Dr. Dolly?
I don't think so that, if she's asymptomatic, then I don't think so that she requires any sort of medical management. What she requires is just observation for 4 to 6 months, repeat her test again, which includes the CA-125, the USG, so that, we come to know that there is, if there is anything suspicious in the lesion. Otherwise, medical management in a menopausal patient is not required.
Okay. In case we think of a medical management, which would be the medicines which we would think of giving this patient?
First, like to know where is the source of estrogen for her, because postmenopausal lady having a recurrence of endometriosis, whether it is endogenous estrogen production or exogenous. Exogenous meaning HRT. Endogenous meaning if she is obese lady and there is peripheral conversion and estrogen production. So that peripheral conversion has to be stopped with the aromatase inhibitor. Letrozole has to be given.
Yes. So for that extra ovarian estrogen production, whichever is coming, aromatase inhibitors can really block that. And this could be an important source for postmenopausal women for that endometriotic cyst which has come.
Moreover, in this patient, the endometrium also has to be evaluated properly if she is having an endometriosis at this particular stage after menopause. So that becomes another important issue.
Yes. Also, many women of postmenopause are on hormonal therapy, HRT. So in case that is the case, then I think we have to stop that as soon as we come across endometriotic cyst, if I'm not wrong. So Dr. Parikshit sir is here.
Yes, I'm very much here.
Sir, what is your inputs regarding infertility? 3 cases, maybe at the end we can take it now.
Sure.
With a menopausal patient which we are discussing, we are moving forward for the 4th case, which is the last case for today. And I think Dr. Harinath would be the one who would be talking right now. So this case is of deep endometriosis. She's 28-year-old. She's having severe dysmenorrhea. She's known a case of endometriosis. She has been taking hormonal treatment, but in vain. Her symptoms have worsened, and we have advised an MRI report. She's come with us with the following. This is just a pictorial representation of what I have written. She's having bilateral endometrial cysts which are obliterating the POD and asymmetrical fluid levels. She has bowel infiltration, which is 5 centimeters long. She has, which is 13 centimeters from the anal verge. The rectal wall, 6 millimeter infiltration is seen, and 25% of her bowel circumference is informed. Now, here we know that this is a deep infiltrating endometriosis, which is it's a nightmare for the doctor as well as the patient. So, I would want to know, Dr. Arthur, sir, what is deep infiltrating endometriosis? How do we define it, or is there any definition?
So basically, in this scenario, deep infiltrating is the one which are the fibrotic bands or the tissue that is developed because of the inflammatory process that has happened due to an endometriotic spot. And especially, it contains fibrous tissue and muscular tissue. It can be between two organ viscera, or it can be over a peritoneal lesion or a retroperitoneal lesion. It can be that kind of a thing. And generally, these endometriotic, when they are vascular, there is an element of probe tenderness which we can elicit over that area. So coming to this question, in this case where the circumference is around 25% and it's a mid-rectal nodule because it is just behind the uterus. So it can be a torus lesion which can be leading to an endometriosis. If the circumference is less than 40% and if it is not involving the muscularis to a great extent, then probably a rectal shaving as a conservative is helpful. But if the circumference is more than 40%, or if it is involving up to the submucosal level, then a discoid excision is helpful. And if it is involving even the mucosa, then a better option would be a resection anastomosis.
Okay. Thank you, sir. Dr. Anupama, can you just enumerate what could be the symptoms of a deep infiltrating endometriosis in general?
Symptom, if it is involving the posterior compartment, then maybe constipation or diarrhea during menses or dyspareunia. And if it is involving the bladder, then they can have cyclical hematuria or pain during passing of urine. So these can be the symptoms.
And Dr. Aarthi, do we have a role of any medical management so far as deep infiltrating endometriosis is concerned?
For this patient or in general?
No, in general, she's a deep infiltrating endometriosis. This case obviously is a direct physical thing. But if we consider deep infiltrating endometriosis, is there medical management? Does it even have a role? Like to do a surgery for the patient, to do all the
deep infiltrating symptomatic treatment you can give, but otherwise going for surgical one is a better option.
Yes. So after surgery, would you like to put this patient on any?
Yeah, that will be better. Elagolix, I think it is a better option.
So your choice would be Elagolix.
Elagolix.
NGIUS.
Yeah. Depending if the patient wants to have one more child, if she's planning for issues, then yeah. Otherwise, going for depot injections, progesterones also helps in such patients.
So no, one doesn't score over the other paper as medical
management.
So surgery in a DIA patient would be indicated in which cases, Dr. Harinath?
Like especially when it comes to DI, as you all said, like there's no much significant role of any medical management. And if the patient is symptomatic, definitely a surgical option is good. And when it comes to surgery, I think these as now I've shifted from laparoscopic to robotic surgery for especially for endometriosis complex scenarios. I think a 3D laparoscopy or a robotic surgery gives the best of the best results. the most important thing is not just the method, whether it's a laparoscopy or robotic, it's the surgeon's skill, especially in handling such scenarios. And if need arise, you can always involve a surgeon, like especially a GA surgeon or a urologist, whenever the expertise is not available, or with a gynec surgeon, or in case better to involve him so that we can do a better job for the patient and a better outcome. Only thing is the person whom you are involving also should be as knowledgeable about the pelvic endometriosis per se, because all the GI surgeons and urologists, they will be very commonly handling non-endometriotic lesions, basically oncological cases and such scenarios. So especially in this scenario, the surgical steps and techniques are a little different from their oncological approach. So they should be aware of what the pathology is and how to help the gynec surgeon.
Exactly.
So definitely, it will require a very thorough surgery, and that gives really wonderful results. Definitely wonderful results.
Symptoms, other indication which I can think of in deep infiltrating endometriosis is when we are doing an embryo transfer, especially if it's a posterior compartment endometriosis, the uterus is acutely retroverted. So the embryo transfer catheter is very difficult to go in. So these are the cases where we request for the release of the uterus so that the retroversion is corrected and our ET catheter can go in. And recurrent implantation failures also, sometimes we need clearance of the deep infiltrating endometriosis.
Yes.
Dr. Rupali had put a photo where the exact lesion was in the torus area.
Yes.
So generally lesions in the torus area causes retroflexion of the uterus, and the embryo catheter, as if it is climbing a hill. So it goes
Doesn't
like
go in
this.
only, yes.
No, it doesn't go in. If at all it goes. So in that scenario, what I have noticed is, instead of holding the anterior lip of the cervix and pulling it, rather hold the posterior lip of the cervix and pull. But as you said, definitely not in all cases that would lead to a successful entry, and there will be a little bit of challenge. So that correction needs to be done.
Rupali?
Yes.
Yeah, you're back. Okay.
Yeah. Can you see my slides?
No, not yet.
No.
No, not yet.
I think there was some technical issue.
Disconnected for a moment.
Yeah. Even I couldn't hear anything actually. Can you see now?
Yes. Please go ahead.
Yeah. So any laparoscopic surgeon, the main goal would be definitely a complete eradication of the pathology where you achieve a long-term pain relief and prevent the recurrence for that patient, and yet to maintain the functional anatomy of the involved organs. So it's a very difficult task for all the lap surgeons, robotic surgeons, and it would be a nightmare to, put in a laparoscope and see that it's a frozen pelvis. So, Dr. Adinath, I'm sure you must have come across many such cases where you're unable to do anything. So, in such cases, how do you approach the patient, or what consent do you take for the patient in these specific cases where you already anticipate that there's going to be some real, you're in deep problem?
I think spending good amount of time with the patient in counseling is the most crucial thing. Like of late, what I've seen is the fertility specialist sends the patients to us with a scan, either by a fetal medicine expert, and then I have only still images and the description given by the doctor. I don't have a full-time video of the scan. So I think as a surgeon, I should know what the pathology. So I do a detailed transvaginal sonography. But some cases where the scenario is a little complex, I don't mind asking for a contrast MRI. And in this kind of an MRI, what I generally do is I fill the vagina with around 50 to 70 ml of scanning gel. And the previous day of on the previous day of doing the MRI, I give them Dulcolac so that they empty the bowels completely, fill the vagina with scanning gel, and even the lower rectum is filled with scanning gel, and then do a contrast MRI. In this scenario, I get more information about the rectovaginal septum, what is happening happening with the torus. And it's not just the radiologist who is going to interpret and give you the reports. I would ask for the films and I would detailed evaluation of the films I do. And in 30 to 35% of the cases which I have managed, I see that the radiologist has written that there are no rectal adhesions. And I have faced scenarios where I have suspected it, and when I go in, there are rectal adhesions. So it's not just one man who can help the patient. It's like repeatedly 3 to 4 people who are especially trained in handling such scenario, or who is going to benefit the patient by giving positive inputs is important. So I
I
keep
think
all the options open. I
I think
keep all the options.
the best, as you said, is the person who's going to operate. If he does the scan, if he's trained to do those particular scans, it would be definitely be an added advantage so far as the patient's treatment is concerned.
One more thing I do is I make a video of the scanning and the MRI films. I just put across on my iPad and I show it to the patient. See, this is where I am finding a pathology. When I do TVS also, if I find a place where I am either the uterosacral ligament or either of the adnexa when I am doing, if I find that the patient has tenderness, I move the monitor to them and show them, see, this is the area where I am suspecting pathology. So that is the area where the ovary is stuck to the uterus, the ovary is stuck to the rectum, and they should be aware that I'm not a god. I'm just a common doctor who is going to try to do the best possible in my hand. So 99.9% of the times there won't be any injury, but 0.1%, they can be a complication which they should be aware of. So if you try to detail your evaluation and show them that the doctor is trying to look for the exact pathology and is interested to give the best of the best results, the patients are convinced and a good outcome is generally possible.
Yes.
We need to counsel pre-op, especially if there is a frozen pelvis, about salpingectomy, unilateral or bilateral salpingectomy we may have to do. Husband consent has to be taken and the patient's consent has to be taken pre-op. This can lead to litigations if this consent is not taken. And also reduction in her AMH level can occur. This has to be explained. And written consent, written informed consent is important.
Nowadays, ma'am, people read on Google and they come and tell us, so after surgery, so my AMH is going to go down, is it?
Yes.
So that is also partly covered by the patient themselves saying that, okay, if you operate, my AMH would go down, right? So we do tell them everything. So it's going to be a little tedious counseling, and a lot of documentation is very, very important.
Okay. So the difficult are those rectovaginal and bowel endometriosis, and as sir has already pointed and told us how they would go ahead. Anything, sir, you have come across where it's a special case where which you would like to tell us? Which you
One case which I remember is one of my fertility specialists. She doesn't do much of obstetrics, but then because they opened up a hospital, she said, okay, sir, I'm starting to do obstetrics nowadays after 10 years of gap. Can you help me with the surgery? Because the patient had placenta previa. So I thought it's just an obstetric case which has a placenta previa. So I went in to help her during the surgery if needed to do an internal iliac artery ligation or whatever procedure in case she ends up with PPH or so. Then after the cesarean section, I'm trying to exteriorize the uterus. I'm not at all able to exteriorize the uterus. That is because she was a case of severe adenomyosis and deep infiltrating endometriosis who on IVF conceived, and I'm not able to exteriorize the uterus. After difficulty, when I tried to pull up the uterus and see after extending the incisions, I see the entire posterior aspect of the uterus is fully frozen. Imagine if I have to do a internal iliac artery ligation for such a patient in PPH or some scenario, or even obstetric hysterectomy per se. I don't think the complication wouldn't be avoided. So it's not just about doing a treatment for the woman to conceive, but I think at the end of the day, it's very, very difficult. Like you said, deep infiltrating endometriosis lesion, if she's asymptomatic, leave it. Yeah, I agree. because there are complications that would arise out of it.
Agree.
But there is a process where when the woman is pregnant, any complication can happen, and that time when you want to operate in a pregnant lady, obstetric hysterectomy if required, and then it is completely plastered. If there is a coexisting bowel injury or a ureteric injury, I am unable to save the lady because I was not able to approach the internal iliac artery easily. So there are certain scenarios which none of the guidelines would tell. Probably it is just the experience and I don't know, God's will, what is written for each person. We don't know. So counseling, having a good rapport with the patient is extremely important.
Yes. So that's true, very true. Counseling for these patients becomes very important. So even for one more point which I wanted to say is just as Madam Archana ma'am also mentioned about the hydroureter. So sometimes it becomes difficult to establish the depth of the lesion because there could be an involvement of the ureteral wall before surgery. And when the only sign could be a hydroureter. So these cases are also not to be missed. And then we have to have a urologist or a neurosurgeon who's obviously, trained to manage endometriotic cases. So is there a need always that along with a gynecologist, when we are managing deep infiltrating endometriosis, we should keep a bowel and a urology or lab trained surgeons to manage this case as well? How do you do it?
Pre-op diagnosis, right diagnosis. If there is bowel involvement, ureter, we should have a good pre-op diagnosis. Then we can keep everything ready, not intra-op. So good scans, good MRI is very important before we operate such cases. And good consents.
Okay, so that was it. Thank you very much. I want Dr. Parikshit sir's input because he's managing IVF infertility patients. Sir, are you there? I think sir is again gone.
Rupali, I think there's also a question in the chat box.
What is it? Can you tell me?
Yeah, to compare GnRH analog and antagonist, I think it's in relation to IVF protocol in these patients.
But then that is the panelists did mention that, we can use those different protocols. But what guidelines say is that both of them have equal pregnancy rates as well as the live birth rate. So they have not come up with anything like GnRH agonist is better than antagonist. And then that can be according to the preferences of the surgeon, of the doctor per se, not anything else. But any of the panelists can take that question as well. But it's already being done. So thank you so
only
much.
One topic is missed with the entire session: scar endometriosis.
It would have taken another 1 hour, so we can again come back to that. I know it was, but 4 cases discussion would be too much, I thought. So we would again come back with, just deep infiltrating endometriosis and with you as the expert. Thank you so much, all the panelists. It was wonderful interaction, and I hope so I've done some justice to, give some take-home messages to all our viewers and all the messages which have come from all the panelists as well. Their in-depth study about the subject, and I'm really very thankful for all this.
I must compliment all the panelists. I must compliment Rupali, Anjum, and the other doctor. Thank you very much for interesting, and I think you all have to be followed. So very nice.
Thank you, madam.
Thank you so much.
Thank you, ma'am. Thank you.
Wonderful panel discussion. Wonderful panel and a very nice talk by Archana. Thank you to all the dignitaries and all participants. And I think Rupali, Anjum and Manila have worked very hard to get it to this point today. I think we all enjoyed this very clinical based and managed based panel.
Yes.
I tried
to make it a little bit clinical based, which helps us, manage our day-to-day cases as well. So I call upon Dr. Priya to give the vote of thanks. Dr. Priya?
Yes, ma'am. On behalf of the AICC RCOG West Zone, I take this opportunity to thank our chief guest, Dr. BASAB MUKHERJEE, and our guest of honor, Dr. MURALIDHAR V. Pai, who is also my teacher, for their gracious presence. My heartfelt thanks to our program directors, Dr. Archana Basir and Dr. Purnima. A special mention to Dr. Archana for her excellent talk, which gave us clear and practical insights. I also thank our conveners, Dr. Manila and Dr. Anjum, our moderator, Dr. Rupali, and all our eminent panelists for the enriching discussion on the recent advances and guidelines in endometriosis management. And of course, a big thank you to all our participants for their active engagement and presence this evening. With that, we would like to conclude today's program. Thank you once again, and we look forward to seeing you all in our future sessions. Thank you.
Very nice.
Thank you. Thank you. Bye.
Bye-bye.
Good night, everyone.
Good night. Good night, everybody.
Good night.